All right, and we're live. Good evening, everyone. Thank you for joining us. My name is Savina Chacheva. I'm the program manager here at the Cancer Wellness Center. For those of you new to the center, we are a nonprofit organization that offers free support, wellness, and education to cancer patients, their loved ones, as well as those bereaved. We're really excited tonight to have Dr. Lauren Wiebe from North Shore University Health System, who will talk about the role of palliative care in cancer. She's really an expert in that field, and we're really excited to have her. Welcome, Dr. Wiebe. Thank you for being here.
Thank you. I had myself muted. It's really nice to be here. We're so lucky we have the Cancer Wellness Center so close to us and such an integral part of what we do every day. So thank you, Savina. For those of you who don't know me, and I know there's at least one who does in the audience today, but I am dual boarded and dual trained. I work at North Shore, but I am both a medical oncologist as well as a palliative medicine physician. Usually hospice and palliative medicine are kind of hand in hand. We'll talk about that more. But I am uniquely positioned. I tend to do GI medical oncology with the gastrointestinal tract. But I do hospice and palliative medicine for all kinds of cancer. So that does not make a difference what kind. Okay, I do have some disclosures. I'm an educational speaker for AbbVie for Korean. So a lot of people, I think I start every visit with what is palliative care. And to take it back to ancient Latin and then medieval Latin, the word pallium was a cloak or a shawl. Palliare was the verb to cloak or to cover. And I think that evolved into either to cover or conceal suffering, or to shawl and to comfort those who are suffering or wounded. Palliative care is a specialized medical care focused on relieving suffering during a serious illness. Our goals are to improve physical symptoms, spiritual or existential concerns for patients and families. And I would say that palliative care is synonymous with palliative medicine, supportive care, supportive cancer care, supportive oncology. Those are all terms that are used in the, I would say, the lay press and the oncologic literature interchangeably. Some are more palatable, I guess. Perhaps easier to sort of integrate or to introduce to patients than others. So some people choose different terms there. And what I consider it is basically a series of conversations and interventions focused on improving or maintaining the quality of someone's life while they're going through some sort of illness. Very common question, what is palliative care versus hospice? So it's the same thing. And really don't be embarrassed. I would say 90% of the doctors I work with don't know the difference. So I don't blame anyone for asking that question. And it's an opportunity to really evaluate what we do. So palliative care is, symptom management, symptom support of a patient during life-limiting illness. Whereas, and I actually just say it's alleviation of suffering in whatever forms that takes. And so hospice care would be within the circle, a smaller circle within the Venn diagram, showing, and in hospice care, it's really symptom management and comfort care at the end of life. So it's kind of the most intense version of the relief of suffering is for patients who are in hospice. And so sometimes I will say, when I'm your palliative care doctor, I'm a supporting actress to your oncologist or whoever that is who's leading the role to prolong your life or cure your cancer, whatever that is. But when I'm potentially your hospice doctor or when you're undergoing hospice, at that point, comfort is your top priority and I kind of step into the limelight and I take over the care completely because it's medically driven that you need that kind of comfort care as a top priority. Also, I think it's important to realize that hospice is an insurance status as well in this country. And so when patients are, getting standard oncologic care, surgery, chemotherapy, radiation, and I'm, let's say as the palliative care doctor, I'm a supporting actress. You have all your regular, insurance works the way it does as we typically know it. But once someone elects the hospice benefits, whether it's through Medicare or through a private payer, hospice becomes the primary payer and responsible party for all of the care that's provided. So that's a little bit of something I think worth knowing. Palliative care can be provided essentially during any serious illness, whether it's curable or not. I would say somewhat life-threatening is basically the bar to cross. It can be provided in any setting, at home, in a clinic, inpatient hospitalizations, nursing home, at a rehab facility, in person, or by a televisit when appropriate, thanks to COVID, actually. Under insurance coverage, palliative care can be provided as any other provider you might see. I think it's almost unheard of now that to find an insurance that doesn't cover palliative care. Palliative care can be provided, so visits can be had as frequently as dictated by any of the symptoms or concerns you might have. I have patients I see once every 6 months. I have patients I see every week or even twice a week in my clinic if things are that intense. Like a lot of times when I get a new referral with some very severe pain. I have a young girl right now I can think of. I have to talk to them and have a visit every 3 days, basically, until we get their pain under better control, or the nausea, or the pain and nausea, whatever it is. And then once things are better controlled, they stretch out to a more, common interval, I'd say. Palliative care is provided by specialized doctors, nurses, advanced practice nurse practitioners, APNs or APNPs. They're quite common because there are not enough palliative care doctors to go around in the world. Social workers help us immensely, chaplains, music therapists, psychotherapists, and many other people. And actually, as I'm saying that, I realized that our palliative care at North Shore, we have our own massage therapy team that is fully dedicated to our patients on Fridays, thanks to a grant we have, which is wonderful. And we provide palliative care, or really anybody should provide palliative care in conjunction with your primary cancer team. And honestly, it works so much better that way. If we know, if we have our finger on the pulse of what you're dealing with while you're going through cancer therapy, it's just so much better. We can really have the most enriched perspective of how best to guide you and help you and answer your questions you might have. You might say, why would I want palliative care? And honestly, the benefits are clear and consistent in the medical literature with clear evidence over the last 10 plus years. Early integrated palliative care delivered in the ambulatory setting, the clinic setting, has been associated with improved quality of life, lower rates of depression, and even prolonged survival, which I think the last one was a bit of a surprise for everyone, doctors and patients alike. Integrating palliative care early into the disease course for patients with cancer. There are multiple seminal studies that have showed improvements in outcomes ranging from quality of life, mood, satisfaction of patients, as well as prognostic understanding. use of health services, so whether people want to be hospitalized or not, and again, possibly survival. I couldn't possibly put all of the references on here that actually support this, but I can provide them if you wish. This was, I would say, the landmark study that really shook the world of oncology, let's say. In 2010, this was published in the foremost medical journal, not a cancer journal, just the medical journal in general, New England Journal of Medicine. And this was a study of 151 patients who had metastatic lung cancer at Mass General in Boston, a very rigorous, well-known institution. And they just said, hey, what happens if we take these patients and we just randomize them, and half of the patients get whatever we do, you know, in our high quality lung cancer clinic, and the other half gets also to see this other palliative care provider, and it was some doctors, some nurse practitioners, once a month. There wasn't any mandate on what happened. It was just an additional visit once a month. And, you know, they noticed a few things. The most surprising, I think, was that the people who got palliative care along with their standard care got about 2 months longer survival compared to patients who were just in their standard clinic. There were also clinically meaningful improvements in quality of life and mood that were also noted. So this study begat many other studies of its kind. And this brings to mind a beloved patient of mine who I met actually not at North Shore, but I took care of her at another hospital. She was 36 and a young mom, and she had stage 4 anaplastic oligodendroglioma, which is a type of brain tumor. It's a really rare one. And she had undergone 2 separate attempts to tolerate oral chemo with temozolomide, plus or minus radiation, depending on the attempt. This is actually not a very tough chemo. I mean, temozolomide it's a pill, and most people tolerate it really quite well without a lot of symptoms or side effects. However, she consistently woke up from a dead sleep, projectile vomiting, I say like The Exorcist, at 3 o'clock in the morning. And so the cancer team gave her Zofran, ondansetron, Compazine, Ativan, steroids. They gave her, quote, everything they knew how to give her, and she still was really miserable. And she said, I met her in consultation, and she said, how am I ever going to survive if I can't even take this easy chemo? I mean, there's harder stuff I know I have down the line, but, this is terrifying. And so I put together a new cocktail of medications for her, and her neuro-oncologist, who is no longer around, let's say, was skeptical of my suggestions and actually told her not to take them. But she trusted me enough that she went ahead, and within 1 day, she tolerated her chemo, slept through the night, and she woke up hungry and ate a big breakfast. And we actually had a long relationship. She lived 5 years after that with a good quality of life. She was regularly playing tennis, traveling. She went to South America with her family. She was doing advocacy work, volunteering pro bono as an attorney. And ultimately, she was able to tolerate these much tougher chemo regimens, BCNU, CCNU, which that's tough. It's tough stuff. Novel targeted agent. She actually lived long enough to see some new agents develop for her cancer and receive them and gain benefit from them. She did CyberKnife of the brain. She got a surgical debulking and this whole second round of radiation, actually when she was diagnosed with leptomeningeal cancer. But basically, she would not tolerate any of that if she didn't have someone helping her with more skills than what her neuro-oncologist could offer. And our relationship evolved, over the years, obviously. And I ultimately served as a guide and a trusted friend to help her and her family with choices as she neared the end of her life. I knew her parents, I knew her siblings, I knew her husband, I knew her in-laws. I mean, it was such a gratifying relationship for both of us, and it just started because she had nausea. Why might cancer patients do better with concurrent palliative care? Now, nobody really knows this for sure, but these are some of my thoughts. So maybe patients have better symptom control. I think they do. With controlled pain, people function better. They're going to do more walking, more eating, more socializing. If you're balled up in pain, you're not going to feel like doing any of those things. With less nausea, people again eat more. They can keep their weight, their nutrition, give them, more energy to get through the day. And also, with less visible toxicity from chemo, patients can tolerate higher doses, like full dose chemo. They don't need dose reductions. They're not kind of belly aching to their oncologist, which I don't mean that in a pejorative way, but, oncologists want you to tolerate whatever they're giving them. And so, if things aren't going well, they're going to start reducing doses, which can be just as effective as not, but we never know. And, if you could take full dose and tolerate it just the same, we might as well do whatever is considered full dose for chemo. So can patients actually tolerate more rounds of chemo or more, appropriate dose, full dose of chemo if their symptoms are well managed or the diarrhea or what have you? And we know patients have less hospitalizations if the family or patient have tools to manage struggles with symptoms at home and don't have to head to the ER. Additionally, I think that a personalized level of support, kind of meeting you where you are, and walking beside you, your priorities, your struggles, is something that, it's just priceless, I would say. And for my version as a physician, it's privilege. It's a privilege for me to be able to personalize all of the knowledge that I spent, 10 years in school trying to develop and help tailor it so that a patient can live their best life. Also, to have a palliative care provider, it's another set of eyes and ears. I'm an oncologist too for a lot of my patients. Oncologists are really busy. There's a national shortage. They're on the 7-minute clock. There are people in my practice who can't really spend more than 10 minutes with a patient just because, that's cool. That's not just my practice. That's everywhere because they're so busy. And so having palliative care, which is a team member who is really solely focused on your quality of life and your process of going through this is really, I think, part of what makes our patients do better. And we know patients with cancer clearly suffer. There's just a lot of evidence, a lot of data. I probably have to tell none of you this, but cancer patients really carry the burden of a significant number of different symptoms along their lives. And that's for curable and advanced or incurable cancer patients. There is also a hesitancy to contact palliative care or consult palliative care for curable patients, and that's by oncologists and hospitalists or primary care physicians. And probably just because they have to explain what palliative care is, and that's not easy. When I do rounds in the hospital or have trainees, I have another resident joining me tomorrow for clinic, my first question is, how would you explain palliative care to a patient? It's a struggle. It really is. I think, I've been doing it for so long, I can do it easily, but that takes more time to explain why you're having someone see a palliative care doctor. So it's just a barrier. It's just a barrier that potentially patients or, patient advocates, caregivers could overcome. We know hospitalized cancer patients are having over 50% incidence of moderate to severe symptoms. So really, people need our help. And we know that both quality and quantity of life are increasingly linked to optimal symptom control. So you are your own best advocate. So a little bit about quality at the end of life. There was a very series of studies, research studies that were very important called the Coping with Cancer study. And then there's been a 1, 2, 3, they've done serial studies now, mostly led by Holly Prigerson. The first one, they interviewed close to 400 patients who had advanced cancer and their caregivers. And that was actually before and then after they passed. Better healthcare related quality of life was predicted by a lack of in-hospital death. Also, in the last week of life, no ICU stay, no feeding tube or chemotherapy in that last week. And then also the less patients were reported being worried about things, i.e. like having someone to help them manage things and plan, was much better quality of life for both patients and caregivers. Having religious prayer or meditation or personalized pastoral care as part of the medical care was a much better outcome for patients and caregivers. Also, the strength of a therapeutic alliance with the physician or physician's team provided immense benefit for both patients and caregivers after the patient might be gone. And so I know that palliative medicine can help with all of these. So what are the indications? So when would a doctor or a patient ask for palliative care consultation? I mean, our criteria that I just presented to the cancer committee this morning, diagnosis of advanced cancer is an easy one. And really any reasonable request from a patient or a family member or a caregiver, as long as the patient wants to also go to that consult, whether the cancer is curable or not, that's a reasonable reason for palliative care consultation. There are some times I have been helpful in early stage cancer as well. Any interest in advanced care planning, talking about what might come or planning ahead. Even people are worried about finances appropriately and what would this look like. I live alone, I have no family. What might be in my future? How could I sort of best plan? Discussions regarding quality of life or treatment decisions and how they might relate to quality of life. And then moderate to severe symptoms that are, bothersome and not responding to current treatment regimens by your primary team. That's a perfect reason for palliative care consultation. So I just wanted to give you guys a sort of a taste of kind of like the basics that I deal with like every day as a palliative care doctor. So this may feel like a whirlwind tour, and it's certainly not comprehensive. But I just wanted to sort of give you a taste of a few key symptoms that I tend to deal with. Pain, nausea, taste changes, diarrhea, fatigue, and cough. So these are just pretty common ones I deal with every day. So cancer pain is an unpleasant sensory and emotional experience, usually associated with tissue damage from the cancer itself, but it could be also from the chemo or complications of treatment. We know that this is best addressed with a multifaceted approach. So if it's related to the cancer, treating the cancer with a cancer therapy is going to be hopefully helpful. And palliative, so whether it's chemo or radiation, hopefully we can knock things back, reduce the issues because of it. But other things are also shown to be very helpful. Coping skills training, which I think is surprising. It was surprising to me when I learned about that. There's cognitive behavioral therapy, mindfulness, and stress reduction. That's MBSR is kind of a buzzword for mindfulness based stress reduction strategies. Like it's also what they're trying to teach doctors to avoid burnout, for example. But also I learned recently about a pain reprocessing therapy, PRT, and that also, so, obviously you have to get your appropriate pain management strategy medically or whatever, but if you can also support it with optimal kind of coping skills training, it could really help with your quality of life and reduce reliance on medications. We know that setting realistic expectations as to what, a tolerable function, patients often are not going to get to zero pain. I mean, I would say I don't have zero pain on a given day, but setting realistic expectations about what can help you tolerate your pain, interact with your family, do the things you want to do, whether it's work or athletics, what have you. We use medications, obviously, and talk a little bit more about those. They do tend to rely on the opioids, like narcotics, when indicated. We do not give them if they are not needed. And in general, the less you need to control something to a tolerable level, that's what we're also going to support you to do. And there are many medications called adjuvants, which are not narcotics, but they help people tolerate pain better than they do just with the opioids, and they are opioid sparing, we say. There's also local and regional interventions. I would say yesterday I had a home run with anesthesia. A dear patient of mine who was hospitalized at Evanston. She has localized pancreas cancer. It's been so hard to manage her pain. And finally, we were able to talk her into getting a celiac plexus block, which for pancreas cancer pain, it's fantastic because those people often have this sort of boring, like stabbing, like someone stabbing them through the middle of their upper belly into their back, because that's where the nerve plexus is. And so, I basically triangulated over a matter of 4 to 5 days with anesthesia, and we really nailed down a strategy, and they were able to do like a bilateral block of her celiac plexus. And within 2 hours, she said she had zero pain. And this is a woman who was on like hundreds of milligrams of narcotics every day. And she was able to leave the hospital in a couple hours, and it was wonderful. And it can be repeated. So, looking at a comprehensive approach can be very, very helpful. And then we cannot minimize the things that, our grandmothers told us about: ice, heat, massage. There's also myofascial release strategies, especially for people who have a lot of, I would say, abdominal scarring from internal, from surgery or cancer, what have you. Those are possibilities. Potentially acupuncture, lidocaine, the cannabinoids in terms of like an ointment can be helpful for reducing inflammatory pain. And Voltaren gel, or an anti-inflammatory gel, as long as it's approved by your other providers. And I also want to just mention, I have no stake in this app or anything like that, but there's an app called Curable, and it's about sort of thinking about pain. And it has some significant data in terms of improving patient experience of pain, mastery around pain, and reducing pain scores every day. There's a free version. I just took one screenshot so you can see kind of what it looks like there. There's a free version, and then there's a version that is sort of more comprehensive that you can also pay for. But it can be very helpful in terms of mentally putting your pain in a place where you feel more empowered around it. So basic principles that I look at when I'm evaluating a patient for pain, I'm going to make medication selections based on what I think is causing the pain. I'm going to look at the other medical problems that someone has and what the side effects of whatever drug I'm recommending, how are they going to interact with the other issues that the patient has. It's also important to look at drug-drug interactions. I'm sure we're all aware of that, but very important to have someone with a lot of experience looking at this. We're always careful of the Tylenol, acetaminophen levels. The totals should be less than 3,000 to 4,000 milligrams a day. Most of us say 3,000. Some even say 2,000, depending on the patient. So make sure you've reviewed that with your oncologist, your other providers. We also look at whether a patient is opioid naive or tolerant, meaning have they been taking opioids? That's drastically going to affect how you will tolerate medications, and it's a safety issue. So it's very important to know and to get a really, really rich history of what we've been taking for pain, how often, those kinds of things. I often want patients to just have me literally walk through their day with them or chart it and tell me what you've been doing for pain. And as part of any, there's the opioid epidemic, which is no joke. And so I think it's important for us to always assess for the risk of potential misuse. And really, for any provider, the red flags, or at least the risks are higher if someone has a prior substance dependence or abuse history, a family history of addiction, and then a history of depression, anxiety, ADHD, sexual abuse, things in the past that might have someone have, let's say, I don't know how to phrase it. I want to phrase it carefully. Let's say potential for escapist type of coping, put it that way. And then younger people are much more likely to misuse or abuse medications. And what I would say is if none of these are true, I get so many people who are so worried that they will not take anything for pain because they don't want to become addicted. And they've made it to the age of 90 without becoming a smoker, alcoholic, or anything else. They're not even overeaters. And honestly, there's almost 0% chance of a patient who has none of these converting to an addict, so to speak, during their cancer trajectory. So we have a lot of data to support that. It can, people can take narcotics very safely in the course of cancer treatment if needed, and do very well on the medications. So proper pain assessment also includes knowing the intensity, the location, and the nature of the pain. And really, I do that also to make sure that this isn't something that could be fixed. Occasionally it is. I'm like, oh, well, there's this thing and it's pushing and we can fix that. Or you have a broken leg, we could put a rod in and it could be better. Or maybe we could radiate something and that would really improve the pain. So I think it's important to always just keep that in mind. I'll want to know people's medication usage and then the efficacy. So level of function, how have you been doing? Does this medication allow you to get out of the house or walk? Do you sleep through the night? I think I ask every single one of my patients that. If not, why not? So is it pain or is it something else? Because I can alter medications for that. I value sleep through the night immensely, so I try to help other people have the same. Duration of the medication effect, and then the degree of benefit. Does it help you a little bit, help you a lot? And then I know how to tweak things the best. I'm always screening for adverse medication effects. Constipation is a very common side effect of pain medications, and I always tell people You'll never develop a tolerance with constipation to opioids, so you're always going to have to take a laxative. Bad news, but it's best to know that right away if you're going to be on laxatives. And then the other thing that's important to know, and I think is not really treated as common knowledge in the cancer world, is that nausea is actually a normal response to the introduction of a drug like morphine or any other pain medication. And anytime we make a substantial change in dose, there's a high risk somebody's going to be nauseated. That's actually an appropriate response to your body seeing a new toxin. And so the recommendation is really if you're at high risk for nausea, particularly if if it's a woman who, for example, we knew was very nauseated with pregnancy, it's very high risk for having any nausea with chemo or with the introduction of narcotics. So we recommend sort of scheduling those like Zofran or Compazine around the clock for 3 to 7 days, just while you're getting used to, unfortunately, you have to take this medication for pain. I want to make sure you can tolerate it well. And so starting Compazine or Reglan, some of the nausea medications, and then adding on Zofran or a drug like Zofran will help you tolerate those pain medications better. It doesn't mean you're allergic to them. It just means you're a normal person. Risk for chemotherapy-induced nausea and vomiting. So that's what my CINV is there. It's an acronym. It's higher if higher risk of nausea if you're young, if you're a woman, if you have like motion sickness, altitude sickness, pregnancy, nausea, or if you're very anxious or someone else thinks you're very anxious and knows you well. And actually a lack of alcohol use in your history. So it's one of those things, I guess, if you're a regular drinker, you've kind of fried the part of your brain that tells you toxins are in your body, so you tolerate them better. Strange thing. We always chuckle about it as doctors because we're like, oh, okay, I'm just working on my alcohol history sometimes when you're going out for a drink afterwards. I also look at if someone's telling me they're nauseated as a cancer patient, are they on chemo right now or not? Because I've definitely picked up medical issues when someone's called me for nausea. And I said, hey, wait, that patient's not even on chemo. So let's look at what that is. So I've picked up certain toxins or withdrawal syndrome sometimes from benzodiazepines or narcotics, or like early kidney failure, or even potentially the rare incidence of, too much medical marijuana actually can lead to some significant nausea if someone's not tolerating it well. Additionally, I have picked up what we call space-occupying lesions in the brain, like a new mass in the brain or something that's causing increased pressure, and thus people become nauseated. People get anxious sometimes and anticipate something and get an upset stomach and maybe don't connect the two. And also poor gastric emptying or constipation or even obstruction can cause nausea in our cancer patients. And chemo-induced nausea and vomiting, so it's usually registered at that chemoreceptor trigger zone in the brain, which is the thing that you can fry with enough alcohol over your life. And there's actually a vomiting center in the brain, and I find the physiology of nausea fascinating personally. And all of these chemicals, dopamine, serotonin, the mu is actually the opioid receptor, histamines, neurokinin-1 receptors, which are actually, we have medications to combat all of these for our cancer patients. And when you might go in to get any cancer therapy, the therapies are all classified by how much we know they're going to cause nausea. And then, thank goodness, there's a whole career of pharmacists that have developed these protocols for pre-medication based on the risk of nausea. And so those are already in place. If you're going to get some sort of chemo or cancer therapy, they've already been assessed, and it's just standard national protocol that we give you sort of what we predict is going to be the best pre-medication based on the risk level of the drugs. And that is based on a lot of evidence and escalating combinations of all of those mechanisms I put there. But it's important to know as a patient and a self-advocate or caregiver advocate that patients can still have what's called breakthrough nausea on chemo regimens. And that breakthrough is having that symptom despite being given the appropriate predicted prophylaxis. And it's really important that your oncologist knows that. I think sometimes patients feel like they don't want to complain. They don't want to be that like bellyacher that I kind of mentioned earlier. But it is actually really important because we do have more tricks. Oncologists have more tricks up their sleeve. Palliative care doctors have more tricks up our sleeves. But it's important that your oncologist knows if you had a problem, because they really can beef it up for the next cycle. And they will actually have to run it through insurance because the fancier drugs are cheap. And so they do need a little bit of time to make sure they can get you better pre-medication for the next cycle around. So when I'm palliative care doctor for someone else's cancer patient, I try to make sure to communicate that back early so that the patient gets what they need the second cycle. And at North Shore, actually, I just send a message to the oncologist and to the pharmacist so that I make sure it gets done for them. But if someone really has refractory nausea, we always need to rule out a bowel obstruction or constipation. You'd be surprised how much trouble constipation can cause. I always check and see if the patient's taking laxatives. I know a lot of people are given Miralax or the generic polyethylene glycol, but that is like a powder that you have to dissolve in 8 to 10 ounces of water. It's a lot of volume, and if you're nauseated, it can be hard to take. So maybe you fall behind on your laxatives if you have nausea. And then sometimes people stop their laxatives without telling their doctor just because they get counseled on risks of chemo, fear of diarrhea, and they're like, oh, I don't want to have diarrhea, so maybe I'll just stop my laxatives. Or maybe they're not on laxatives and they're not needed or recommended quite yet. So it might be time to start. And I really like to remind people that chemotherapy pre-medication, so all of those things I told you that sort of get given if you're getting chemo in the chemo chair, they're very heavily constipating. And I mean, the stuff they give like, for any moderate to highly emetogenic chemotherapy, they're going to give you 16 milligrams of IV Zofran plus maybe 8 IV dexamethasone or steroids. And I mean, that's a recipe not to poop for 5 days in your average patient. So average person, not even patient. So the way I tend to do it, I tend to schedule heavy laxatives on day 1, 2, and 3 of the cycle, and then maybe have a day crescendo over the next week so that, week 2 isn't pure diarrhea. So that's an art. You work with your oncologist, you work with the particular regimen you're on, you work with your kind of pre-existing thing and see how it's like cooking. You have to kind of just try the recipe, see how it happens, change it for the next cycle. And communication and prioritizing your symptoms is really important. Another thing I would say, if someone has nausea, we often prescribe, as physicians, we always prescribe nausea medications, and patients have them in their hot little hands, but they may not actually be taking them, which is very common in patient. I get a lot of consultations. Oh, we have the patient on everything and they're still nauseated. And I see, yep, they have a list of medications. They have all the right medications ordered, but they're not actually getting them because they have to ask for them or something like that. So we might have to say, you have to take these 3 times a day, and then next time it's better. And then another common pearl that I find is that people don't realize that different types of nausea medications need to be combined for the best effect. And so sometimes people say, oh, this one doesn't work, I'm just going to toss that in the bin, and then I'll focus on this new medication. But ultimately, if you go back for just a second to all of these different mechanisms that all contribute to the ultimate go or no go on a vomiting center, we really do have to use numbers of strategies of meds to hit the most effect for some of our patients. Quickly, I just wanted to touch on taste alterations, which affects so many of our patients on or after chemo, and then newly with COVID, but that's a whole nother thing I don't want to talk about. I don't really know anything about, actually. I always say if someone has funny taste or even trouble swallowing, let's rule out a fungal infection like thrush. It's very easy to miss. Someone has a heavy film on any part of their mouth or their tongue. It's easy to miss. People think it's just poor oral hygiene, but it's also really easy to treat, whether it's with a swish and swallow solution or with a antifungal therapy like fluconazole, a pill a day. So it's always good to rule that out. I also put in here, just as a interesting fact, pancreas cancer patients, about 50% of patients report taste alterations prior to getting any chemo. So we think it's something to do with the kind of the hormonal milieu of what gets produced by the cancer, that people's taste just changes. But something I think is really useful is that patients get zinc deficient. Now, this isn't something that anyone's going to check for. It is not worth testing and measuring zinc levels, but it is shown to be subtle and acquired, whether it's through just cancer or chemotherapy or dietary changes. But zinc tends to track with dietary protein intake. We know that a lot of patients, whether it's cancer or chemo, are just kind of averse. They don't feel like drawn to eating a lot of protein. In fact, some people who are huge meat eaters may just completely skew away from meat for some reason based on taste or preference. So zinc levels, and then also whether chemotherapy kind of selectively changes the gut flora, that there's something about the zinc absorption. We don't really know. All I know is there are studies that show that a trial of zinc supplementation, about 50 milligrams of just the standard vitamin over the counter, 3 times a day with meals in a couple of weeks, 3 or 4 weeks, 2 to 4 weeks, can sometimes restore people's taste and the taste quality, the taste, perceptions while on chemo. And really minimal toxicity to taking, a tablet of zinc 3 times a day. Most people tolerate it beautifully. I say try it for a month. If it doesn't work, you can stop it. We don't want you taking pills you don't have to, but it's worth a try if that is an issue. And I'm not talking about those Zicam or whatever, the zinc lozenges. No, they're just going to ruin your taste. It's actually just zinc as a tablet. So that's worth a try. Diarrhea. Just wanted to touch on this for a few pearls. So of course, we're going to rule out kind of a standard infection, or if you've been on antibiotics recently, you could get C. difficile, which is a treatable infection. It can be very annoying, sometimes recurrent. And we're going to make sure a patient who has diarrhea needs, gets their hydration properly, electrolyte repletion. One of the really nice things about cancer medicine is that we have outpatient clinics where we can give you IV hydration, we can check your blood and give you a blood transfusion, you know, all kind of without having to go to the ER. I know we have at our Kellogg Cancer Center, we actually have our own immediate care, which is really nice because, you know, it's our and nurse practitioners, it's our physician. They call me as the treating physician, so I can give the oversight of what the best thing is for my patient, and they can just do a scan right there. They can, you know, give them antibiotics, blood, stuff like that, which is really nice in a pinch. It's weekdays only, but it's nice to have that because we can just give you IV fluids if you need it. So diarrhea should be treated a little differently depending upon the cause. So obviously, if it's infectious, you want to treat that. But if it's due to standard kind of what I call old school chemotherapy or any of the more targeted agents, like some of the Tarceva or some of the oral pills that are kind of treating cancer, you know, we can manage those either with dose reductions, kind of we talked about before, like, okay, that dose is too intense, let's reduce the dose, or we could try to manage with over-the-counter loperamide, which is Imodium, or Lomotil, which is a prescription. And you can really take 8 tabs in 24 hours. I mean, that's a pretty common oncologic dose. Definitely should be informing your cancer doctor if we're anywhere near that. And they do have to clear whether you can take Imodium or Lomotil. But if you have diarrhea as an expected side effect of a given cancer therapy, usually they're okay with you taking Imodium. They should just know. Your oncologist should just know. And more severe ones, I mean, these are rare, but if we know you need X treatment, X chemotherapy, and you really have to be on that, we need to have you on it. For more severe cases that don't respond to 8+8 of the Imodium plus Lomotil, we can do tincture of opium, which is a non-absorbed narcotic that can constipate essentially. We do some octreotide, which is subcutaneous IV, short or long acting. But again, those are going to have to be in conjunction with your oncologist. I mentioned immunotherapy. I know a lot of people are on immunotherapy these days, which is kind of a training of your immune system to fight the cancer instead of using toxins to fight the cancer. I will say with that one, any loose or diarrhea, loose stool is extremely concerning. So we're not going to give the, you know, sure, take 8 Imodium, 8 Lomotil, beef it up, take whatever, just get the bowel slowed. That's not the right approach with immunotherapy, because immunotherapy itself never gives anybody diarrhea. It's the body starting to attack your own intestines. So your doctor definitely needs to know about that. And your oncologist 100% needs to know. Even if it's only a few more bowel movements than you usually have, you might start to need IV steroids to try to quell your body's immune response if you're having a really robust response to the immunotherapy. You'd be surprised. So I just really, really want to put that out there. And every time I lecture any, general hospital medicine or primary care or even palliative care providers, which do a lot of lectures for that, I always make sure to let them know that we have to take that seriously, very seriously with an immunotherapy patient. And then my final little pearl, not to be missed, is for pancreas cancer patients or people who have a mass near the liver or in the upper intestines. Let's never miss what's called pancreatic exocrine insufficiency, which is basically, all of our bodies are supposed to have a pancreas that makes these digestive enzymes that digest fat, protein, and sugars. And the most important part of that is fat malabsorption, which is what the exocrine insufficiency is. So basically, those enzymes aren't getting to the food to digest it appropriately. And so people end up with this sorry, I hope nobody's trying to eat dinner during this lecture, but I forget sometimes it's not normal to talk about poop a lot. But basically, it's very drippy and urgent and stinky and accidents. It's really hard, and people lose weight really fast in that scenario. And we don't even need to test for fat malabsorption. We can just give a trial of replacement pancreatic enzymes taken with food. And honestly, some of the most rewarding experiences I've had, I mean, I had 3 patients earlier this week who merely the addition of a pancreatic enzyme for digestion has put like 2 pounds back on their little tiny bodies, every week. And watching them regain even their serum proteins, their labs get better, they gain weight, they don't have diarrhea anymore. It's just very gratifying to watch. Another thing, cancer or cancer treatment related fatigue is quite common. We define that as fatigue that's present over a long time, interfering with function and not completely relieved by sleep or rest. And so I, of course, included a picture of my pet bunny, Cinnabon, who is very good at illustrating fatigue. He naps a lot during the day. There are so many things that cancer patients suffer that can cause this. So cancer, the treatment of cancer, the medications chosen, pain, chronic pain is or untreated, unmanaged pain is going to lead to fatigue, wearing you down, deconditioning, depression, anxiety, anticipatory grief, anemia, low blood oxygen levels, infection, caloric deficit or nutritional deficits, or sleep disturbance. So there is a set of interventions that can help. Treating any reversible causes that were shown on the prior slide. Education actually does improve the situation. Behavior modifications, honestly, realizing that it's going on and figuring out a way to adapt and adjust lifestyle to maximize your benefit, and realistic goal setting. I mean, you're not going to clean, the entire basement in 8 hours. I mean, I don't think I could do that, but I mean, just figuring out what things you want to prioritize, and it may be activities, it may be people. You might say there's certain people I really want to prioritize seeing in these certain windows of time that tend to be the best time for me throughout the day. I will say education and behavior modification actually beats medications in clinical trials when randomized. So learning to kind of cope with the things that are potentially dragging you down, like fear of the experience, the whole shebang. I mean, being in a hospital, for example, nobody's getting rest in the hospital. So learning to kind of manage yourself, similar to the pain experience, actually can really help. Exercise actually has the most data for helping cancer patients with fatigue. I feel always a little bit guilty saying that, because I feel like people are tired and the hardest thing to tell someone to do is to exercise. And also I feel like there've been long sections of my life where I've not been able to kind of muster the energy to exercise. So saying that to someone who's going through chemo or has pain, it just feels hard sometimes. But that being said, it does have a lot of data. Aerobic exercise during and after chemo for solid tumors produced a significant reduction in patient-reported fatigue scores. Simple yoga, breathing exercise, qigong can be very helpful. Of course, there's limitations. It's really hard to do this when you're in the position. And then, of course, there's probably some sort of bias in these studies because people who sign up for an exercise study might have been interested in the first place, but it's what we have. Pharmacologic interventions for fatigue include, I'd say the most data is behind methylphenidate, which is also known as Ritalin. It's probably beneficial, but there's a lot of mixed evidence. There's also benefit for placebo in the studies that looked at placebo versus Ritalin. And we tend to dose it at 5 mg to start in the morning and at midday. And then, with appropriate physician guidance, you're going to go up potentially as high as 30 to 40 milligrams a day in those studies. There's a lot of caveats. There's a lot of medications you cannot take methylphenidate with if you have a history of arrhythmias, blood pressure issues that are uncontrolled, unmanaged coronary artery disease, and I would say anxiety. Putting anxious people on Ritalin is a terrible idea. So I would screen for that before, because they just get more anxious. So I would screen for that. Dexamethasone is also a great medication for fatigue, but it's really a 2-week drug. You're not going to get more than 2-week benefit out of it. And you have to be very careful if a patient is on immunotherapy or is about to take, maybe in the next month, is about to start or take immunotherapy, because steroids are what kind of quell the immune response that we need someone to develop while on immunotherapy to fight the cancer. Finally, there are some strong data that support ginseng, and it's about 2,000 milligrams a day versus, placebo. There was a benefit. I will say most cancer doctors are probably going to want to know if you're on ginseng. Some people would say you can't take it. I think you probably can, but it does depend kind of what you're getting in terms of your treatment. I think this is my final symptom slide, but refractory cough is pretty common and can be caused by a lot of things in the cancer setting. Different things that can irritate the lungs. There are basically some starter medications like these Teflon pearls. Benzonatate is the other thing it's called. You can kind of numb the stress receptors in the lung. It has a limited benefit. It can help sometimes at night, especially. There are some data for low or escalating dose of opioids as needed. PRN is always as needed. Sorry, it's just endemic in our language as providers. And any opioid. Some people think you have to take codeine, like as a cough suppressant, but really every opioid is the same. Codeine actually is not an active drug. It has to be metabolized into morphine. So if you're taking codeine, you're actually taking morphine. And then just so you know, since I'm on the subject, there are a lot of codeine non-responders because you have to have a certain enzyme in your liver to activate the codeine. So if you're not responding to codeine, don't be afraid to say, hey, maybe I should be on a different drug. There's just certain people in the population who don't respond. Oh, which also brings me to, there are Zofran non-responders. I feel like the most common drug passed out in oncology is Zofran, otherwise known as ondansetron. It is a great drug. It's a serotonin blocker, very good at controlling nausea, but don't be afraid to say it doesn't work for me. Sometimes people give a 4 milligram dose. 4 milligrams may not be sufficient. Standard dose for cancer therapy is 8 milligrams. So if you're getting 4 milligrams, it's probably not, if it's working for you, great. But if it's not working for you, because there's a higher dose that probably needs to be had. The other thing I was going to say is there are people who have some genetic polymorphisms in the way that their liver enzymes metabolize medications. And there are people who literally are Zofran non-responders, about 20%. And so there's other things we can do. There's like Kytril, which is otherwise known as granisetron. It's a little harder to get. Doctors have to fight a lot harder for it. I don't know why, because it's been around for over 20 years and you would think it would be generic by now. So I don't know why it's still expensive, but that one is completely effective in patients who don't respond to Zofran. So sorry, I got a little sidetracked there, but thought it was worth mentioning. I have a lot of tidbits like that might pop up. So back to cough. So people who have cough, whether it's chronic non-cancer cough or a refractory cancer cough for whatever reason, there is increasing evidence that central reflex sensitization in the brain is important in that ongoing chronic cough. And so some people may burn out, like opioid, cough medicine's not working. There is a lot of data to support the addition of either Neurontin, which is gabapentin, or pregabalin, which is Lyrica, to sort of alter that chronic input and to sort of downregulate the cough response. And so I've had a lot of success with patients with these medications. Risk, and there's data to support it too, of course. And I would just say if you're going to alter or add gabapentin or pregabalin, I always try to avoid doing that on the same day that I'm changing any narcotics, just in case one makes people more tired. So I'm just going to briefly touch on North Shore's palliative medicine services because that's what I know about and I feel very passionate about. So we have specially trained palliative care inpatient units at each one of our flagship hospitals for both hospice and palliative care, where we do monthly educational learning with our nursing and patient care staff. So even the PCTs and the nurses assistants, we sit with them and kind of review a lot of things that we feel are important and answer any questions they might have. That was on hold during COVID, but it is back in place. We have an annual regional palliative care symposium. Sometimes it's for patients. Last couple of years, it's been for providers with the University of Chicago. That's been on hold because of COVID, but it is coming back next year, I believe. We work pretty closely or on site with our preferred sort of skilled nursing facility providers, and our palliative care advanced practice nurses are actually on site rounding with the teams at some of those facilities. And also we're very proud to say we are in ACGME, which is a graduate medical education governing body. We're a formal training site for our hospice and palliative medicine fellows who rotate from the University of Chicago, as well as our residents. And we have 4 half days per week at our cancer center sites, Kellogg. I do 2 of those 4 half days a week. On average, we have about 50 visits a month at Kellogg, and half of it's for symptom control, other quarters for goals of care, and some of it's both. Some of this are both. We tackle everything. We also have a home or a nursing home-based palliative care program, which we call the Symptom Support Program, SSP for short. And patients are seen by either a doc or a nurse practitioner every, I would say, 2 to 8 weeks as the clinical need arises based on the patient scenario. We do really try to restrict that to people who can't come into the clinic. It's too difficult for whatever reason, or just very cumbersome. And it's also important to mention it's not like, oh, I have a symptom and a nurse practitioner just magically pops up at your house. I mean, it's a scheduled visit. It's not an urgent type service. And that's anywhere, it doesn't matter who's providing, which agency or what have you. Palliative care is available as an addition, I would say, but it's not going to be your workhorse of home care. And a lot of those patients end up transitioning to hospice at some point with us. And we are lucky we have a dedicated palliative care social worker who is also an LCSW. She is available free of charge for our patients, and she is fantastic in terms of, I would say, life planning, life review, anticipatory grief management, family kind of alignment. Sometimes there's familial discord or different understandings, and so she can do family meetings. She sees people in all capacities, which is really nice. And also we benefit from continuity because we have the same providers from palliative care to our own hospice, and we have an integrated team. So I wanted to thank you. I don't know how long I've been talking, but I am open to questions from the chat. I have a few resources on here, not too many, but feel free to reach out and then I can open for questions. So
Thank you so much, Dr. Wiebe.